Okay. All right, so give it a few seconds and we'll get started.
Yeah. Jeff, I just have a few things to say if you don't mind me jumping.
No, absolutely.
Okay. I guess I'll go ahead and start. I think most of our members are probably on, and we're very excited about this being our first virtual meeting for the AOE. The fact that Dr. Miller was willing to move this from an in-person to a virtual meeting, I think, is a tribute to his passion with the message he's going to give us today. Everybody's seen his bio, understand where his training was and about when. And from what I understand, it's been about 15 years that he's taken this passion of his for cone beam and the information that it tells us. We orthodontists have known where the bone is forever. That's been the core of our education, is where's the bone, how are we going to use it, where can we put the teeth and still keep it in the bone. But he obviously realizes the limitations of 2D and is very excited about what we're learning with 3D. And I think that that's such a valuable information we're going to get in this era of clear aligner companies not requiring any x-rays at all and no in-person exam, yet they still want to move teeth around orthodontically with their clear aligners. His message of us understanding fully how 3D helps us and guiding us not only in our planning but evaluating our end results, I think is exactly what he mentioned in his title today, how it will help keep orthodontics in the specialty area. That's exactly what we want to be known as. We want to be known as the specialists for moving teeth. So, Dr. Miller, thank you very much for taking the time to rearrange all the personnel that you needed to do to make this happen and to bring this message to us virtually. There will be opportunities for questions. If you'll use your chat function to send the questions, I will make sure that Dr. Miller knows that, and he has breaks in his lecture so that we don't go too far away from the topic that your question is on. So you have that control at the bottom of your screen. Just hit chat and type in your question, and it will come to me, and then I'll manage it from there. So welcome, everybody, and let's give a big round of applause to Dr. Miller.
Okay, well, first of all, thank you. Thank you so much for the opportunity to speak to your distinguished group of orthodontists. I appreciate the opportunity. And today the title is Alveolar Focused Orthodontics, and why, in this orthodontist's humble opinion, I believe that orthodontics will return to the specialty arena where it belongs, regardless of whether the orthodontists participate in that movement or not. I think it's inevitable, and I'll explain, throughout the talk, why I think it's moving in that direction. And if you're listening to this talk, I assume you believe that it belongs in the specialty arena. I'd really like to give a special thank you and shout out to Dr. Ron Jawar. He had to pivot several times to get this thing to fruition. And I can tell you, with the emails and the conversations I've had with him, he is 100% dedicated to our profession of orthodontics. And your group is really, really fortunate to have someone like that. It's inspirational to see that. And I don't believe there are people like that come around every day. So thank you, Ron.
You bet.
During the talk, you can use the chat function on the Zoom toolbar to send your messages to Bob. What you'll do is you go to chat, and it'll give you a list of the participants. Just click his name and type in whatever questions you may have during the talk today. Now, I'm speaking to you from Catonsville, Maryland. Catonsville is a suburb of Baltimore, and I'm speaking to you from the Dr. Aaron Schaefer Center for Advanced Orthodontic Education. Dr. Schaefer was a mentor of mine. He was actually a co-resident with Dr. Ricketts, of all things. So that gives you an idea of his vintage. He passed away about 7 years ago, but we worked together very closely for about 25 years. And if there are any residents or younger orthodontists in the audience today, I would strongly encourage you to consider finding a mentor and trying to build a relationship with someone that has, experience. And I think it's extremely valuable for what we do in orthodontics. If you think about it, it takes 2 years to treat a case and maybe 3 years for the case to fall apart or to see if what you did worked out or not. And throughout a career of 30 to 40 years, that's not really that many cycles. So I think with orthodontics, it's important. And I think for me it was extremely fulfilling, and I believe it was for Dr. Schaefer as well. I'd like to thank the folks at Prexion for co-sponsoring this talk today. We have 5 of the Prexion machines in our offices. We also have iCAD Flex, we have the CareStream, and of the 6 doctors in our practice, they clearly like the Prexion unit the best. If you're considering a cone beam, it's worth taking a look. The Western Regional Sales Manager is Tim Moling. His email and his phone number are on the screen. I'd also like to thank Diamond Dental Supply. They are the manufacturer's rep for Prexion, and they have also graciously co-sponsored this talk today. The Director of Sales is John DeFrancisco, and his phone number and email are on the screen. In terms of an introduction and what we're going to talk about today, one thing we won't talk about is COVID, other than to say I hope everybody's healthy and safe. And if any of your loved ones are infected by the virus, we wish them a speedy and complete recovery. Today, we're going to talk about just some we're going to start off with some housekeeping items. Then we're going to go right to how reliable is cone beam CT, and what is with the 0.6 millimeters of non-visible bone that you frequently hear about. And then we'll talk about how does this relate to the periosteum? How do we know if the periosteum is intact, if it's been compromised by our orthodontic movements? From there, we're going to move to adaptive resorption. These are things that we can visualize using cone beam CT that really, prior to cone beam, we weren't mindful of. And adaptive resorption and retreatments fit together. And from there, we're going to get to, I guess, the meat and potatoes of the talk, which is what is the role of the alveolar housing? Now that we can visualize the alveolar housing on an individual tooth, this wasn't possible before. How does that affect what we do as orthodontists? I remember when I started with cone beam, I would try to run around to any talk on cone beam that had to do with orthodontics, I would try to go to. And at the end of the talk, you would always hear somebody say, how does it change what you do in terms of your treatment planning and diagnosis? And the speaker would always come up with the same answer, and it would be something like, well, I see I'm getting more information, but it hasn't really changed my treatment philosophy. And I believe that cone beam has to change your treatment philosophy. Once you become mindful of all these little nuances that we now can visualize, it's just logical. It's illogical that it wouldn't change, and it's logical that it would. Then we're going to compare diagnosis with cone beam as it compares with our CEP and PAN. I think that's important. And then if we still have time at the end, I'd like just to talk about extraction mechanics, because when you start to view orthodontics from the perspective of the alveolar housing, or you can include the alveolar housing in part of your diagnosis and treatment planning, then delaying extraction space closure can affect the alveolar housing integrity. And that's, I think, an important thing to go over. And then we'll conclude with, why I believe that all these things are moving orthodontics back to the specialty arena, whether or not the orthodontists participate in the movement or not. We'll pause throughout the talk to take questions, and you'll chat those questions to Bob, and he'll present them. Okay, so we've all seen these systems, the 6-month smile and fast braces. These are systems that are marketed to general dentists mostly. I don't personally know any orthodontists that use either of these systems. And the training is basically you go in, you go for a weekend or a day, and you learn, you get certified, and then you start using this or incorporating these things into your general practice. Now, if that's not bad enough, now we have all these do-it-yourself systems. Bob had mentioned you don't even need a dentist to get your teeth straightened. There's more than just a few of these things all over the internet. If you look at the bottom right, that is something like a preformed tooth positioner. And I remember when I first started in practice, someone had given me a couple boxes of these TP preformed tooth positioners. They were called pre-finishers, and they came in different sizes. And they were either 50, they measured from cuspid to cuspid, and you would then set it, you would match the size of the patient's arch to the preformed tooth positioner, and then they came in different extraction patterns. And I remember I had a patient early on, and she came in, and she had some relapse from previous treatment, and she refused to wear braces, and I gave her one of these tooth positioners, and I said to her, exercise with it 2 hours a day, and then come back in a month. And she was just one of these people that was wired. If you tell her to do it 2 hours a day, she probably did it 5. So she comes back in a month, and her teeth were perfectly aligned, and I was shocked. And I was like, wow, is this going to put us out of business as orthodontists? This is unbelievable how well this worked. But what was I using to measure her result? I was really just looking at the clinical crowns. So when you're just looking at the clinical crowns and not including the pan and ceph into your evaluation of the result or the diagnosis, orthodontics becomes the mechanical alignment of the clinical crowns. And in the general dentist view, and when you talk to them, they might talk about some other, talk some stuff, but the bottom line is their worldview of orthodontics is the mechanical alignment of the clinical crowns. So when you add the pan and ceph, it adds a layer of complexity. It's more information. And now that we have cone beam CT, the 3D adds even more information. So it makes orthodontics more complex in terms of what we do when we start moving teeth. And as an analogy, if you take a look at this gentleman in the white t-shirt, and you were trying to evaluate his behavior based on the photograph of just him, you're not really sure what's going on. And it's the same thing when you're just looking at clinical crowns. But if you add additional information, then you see the guy appears to be talking to a statue. Is that normal behavior? But then if you add a 3D element to it, you see he's wearing a Bluetooth earpiece, and maybe you would change your assessment on whether his behavior is considered normal or not. And it's really the same thing when we talk about 2D evaluation of our orthodontic cases versus 3D. Now, of course, everybody's familiar with the 3D reconstruction of cone beam, but really it's the individual slices that provide the diagnosis. That's where the heavy lifting occurs. We all know the historic literature regarding changes to the lower intercuspid width. And pretty much all the literature points in one direction, and that is If you change it, the case is likely to be unstable, or the more you change it, the more unstable the case is likely to be. And then, of course, we have Andrew's 6 keys of normal occlusion, where he studied 120 cases of patients that he considered to have fairly well-aligned arches. And really what he recorded is where Mother Nature placed the teeth. So when you consider our historic literature, and you consider Andrew's 6 keys of normal occlusion, and you consider that evolution of man has not really changed since 1972 when this study was published, and then you show a case like this to orthodontists, you get all kinds of different opinions of this case. Anywhere from, this is a really well-developed case, it looks great, to this case is completely mismanaged. So where does this discrepancy come in between orthodontists that, at least when they're doing their training, learn the same historical literature? And I believe that a lot of it has to do with the inadequacies of cephalometrics when you compare them to 3D. So when you're looking at cone beam and you first get into it, your tendency as an orthodontist is to look at it and try to relate it to a cephalometric x-ray. And then as you go through it, you start to become aware of things that you weren't even mindful of before. And that's really what I want to talk about today, to explain why I believe orthodontics is moving back to the specialty arena. If you also think about it, more and more orthodontists are using bonded lingual retainers. With bonded lingual retainers, the orthodontist can actually violate many of the rules or the traditional rules of orthodontics and pretty much get away with it, at least in the short term. But at what point is that patient considered finished with active orthodontic treatment if they still have an appliance in their mouth? So, you know, I believe what this has done for our profession is it's minimized the debate over long-term stability. You know, prior to lingual bonded retainers, you know, this was a big part of, you know, whether you use one treatment strategy or another. And now, you know, when was the last time you saw a journal article or someone speak at the annual session and talked about long-term stability? We also have all the aligners being marketed to us daily. And I unfortunately believe that aligners have dumbed down orthodontics to the clinical alignment or the mechanical alignment of the clinical crowns. And this is the worldview of the general dentist. It's only the alignment of the clinical crowns that they're concerned about. To them, success of an orthodontic case is whether or not the crowns are aligned. There's no consideration for the roots or the underlying alveolar anatomy that supports those roots. Just have to mention a few things here. First of all, you'll notice that a lot of as I show you my cone beams on the cases, you'll see that they are open. They're out of occlusion. I am not trying to reproduce a cephalometric x-ray. I'm looking at individual teeth and the alveolar bone that supports it. We'll discuss it later when we get to the cone beam versus ceph pan analysis. But you'll notice that a lot of the cone beams will be open, out of occlusion. If you asked orthodontists, or if you ask most orthodontists, what will cone beam replace cephalometrics in the future as our primary diagnostic tool, most all of them will say yes. But if you asked a follow-up question and you say, you know, what is it about cone beam that makes it more valuable in terms of diagnosis than a cephalometric panoramic analysis, you get different answers. You get anywhere from, well, I like to show my patients the 3D reconstruction because, you know, I want to show them that I have better technology than the guy down the street. I can look at things relative to each other in 3D. I can look at super erupted teeth and their locations. I can better locate impacted or ectopic teeth. I can look at the temporomandibular joint from 3 planes of space. I can identify pathology. I can look at the sinuses to see if there are any issues. These machines are not only sold to dentists, but they're also sold to ear, nose, and throat physicians as well. I can take a cone beam and at the end of my treatment and look to make sure all my roots are parallel and well aligned. And of course, I can look at airway. Now, all those things are legitimate uses of cone beam. But what I hear from orthodontists is, well, why do I need a cone beam? Because I don't do airway. And I think that's not the point. I think the point of cone beam is to look at individual teeth and the supporting structures. Now, when you look at cone beam, I think one of the tremendous values of it is to look at our early to middle mixed dentition patients and look at the eruption patterns of these teeth. If you look at this cone beam of this patient, you can see that we have potential collisions going on with the erupting cuspids. Knowing that in advance is, I think, tremendous. We can also take measurements off the cone beam, although for just display purposes, I did it on the 3D reconstruction so you can see it. You can take accurate measurements and do space analysis. And, you know, maybe once you get that information, it may change what you want to do. But what is it that cone beam can provide that's not available from any other radiological source? It's the ability to look at individual teeth and their supporting structure. Now, as orthodontists, we're so ingrained to cephalometrics that we migrate right away to the sagittal view. The sagittal view is just one view. We have the axial and the coronal views as well. And when you start piecing these things together, we can, for the first time, really visualize the limitations of orthodontic tooth movement for an individual tooth. Now, if you look at this axial view and you notice the two lower central incisors here, these need to be brought forward to align with the other incisors. Notice that this patient has some clefting of the alveolar housing there. Knowing that information would probably change what you do as an orthodontist, or it should. Okay, you can't have a discussion about cone beam with orthodontists without first talking about, is it reliable? You know, what's with the 0.6 millimeters of non-visible bone? You hear that if you listen to the AAO annual session that was online. I wish I would have counted how many times people referenced the 0.6 millimeters of non-visible bone when they were talking about cone beam. And then how does this relate to the periosteum? We'll assume for the talk that a dehisced root is going to be more susceptible to tissue recession or tissue dehiscence, okay? And that a root that's well supported by bone and has no exposure is less likely to have tissue dehiscence. I think it's a reasonable assumption, and that dehiscence and fenestration, although not completely avoidable in orthodontics, is a negative consequence of orthodontic treatment. It's not realistic to think as an orthodontist you're never going to dehisce or fenestrate a root. It's not possible. Sometimes you have no choice, and I believe that it's not a realistic expectation. But I think what is realistic is to try to minimize the dehiscence or minimize the magnitude of the potential dehiscence from our orthodontic treatment. So the first question is cone beam able to diagnose dehiscence and fenestration? And why does it matter? So just to give you an idea, if you look at this patient, this is pre-treatment, and you take a look at the axial view of their lower arch. You can see here that lower incisor, if it's rotated, but if you straighten it out and align it, it's not going to fit in the alveolar housing, okay? It's already dehisced. So when we start orthodontic treatment on this patient, unless we do pre-surgical or arch augmentation, where we add bone prior to moving the tooth, we know that that tooth it's already dehisced, but we know that we're going to further dehisce that tooth. If you look at these measurements, you can see that that ridge is about just under 4.5 millimeters, and the root is just about 6.5 or 6.3. Well, that's a discrepancy of about 2 millimeters on a root that's already dehisced. So what happens when you orthodontic try to maneuver that tooth? Well, here's what happened to me. So this patient, we put brackets on, we started to align the tooth, and the tissue stripped. We took took the lower arch wire out and sent it to the periodontist. For some reason, he never made it over to the periodontist. You notice that the tissue did not come back. Now, I could show you another patient we did this on, and the tissue looks absolutely fine. The dehiscence of the tissue doesn't generally happen while the patient's in active orthodontic treatment. It's a lagger. It takes 5-10 years for it to show up. But in some cases, if it's the right combination of a thin tissue biotype or for whatever reasons, that it pops up sometimes. Here's a patient 20 years post-active orthodontic treatment. If you notice, she has dehiscence on her lower left lateral, lower left central, and lower right central. And the magnitude of the dehiscence on the lower left lateral is more than the lower right central. It works its way in magnitude. The pan and ceph are not capable of diagnosing dehiscence and fenestration. It's just not a tool for that. The focal trough on the ceph is just so wide that you can't possibly see what's going on an individual tooth. Now, sometimes if the dehiscence is such a high magnitude, you can see it on a cephalometric X-ray, but rarely do you see it on a ceph. But when you look at it from a cone beam, and here's her cone beam, you notice that those 3 teeth are the 3 teeth that are dehisced. And when I first looked at her when she walked in our office, I thought she was brushing too hard. But then I noticed, that there's no other area of her mouth with tissue dehiscence. And you also notice that the magnitude of the root dehiscence comports with the magnitude of the tissue dehiscence in this particular case. So if you remember from histology, you put an orthodontic force on a tooth, you get osteoclastic activity on the compression side, and you get osteoblastic activity on the tension side, okay? Everybody knows that. There's no problem when you're moving the tooth within the alveolar housing. If you keep the tooth within the alveolar highway, nobody seems to have an issue with that. Bone remodels, the osteoclastic, osteoblastic activity take care of everything. But when you start putting a buccal or a lingual force on a tooth, the leading edge of that root, the periodontal ligament space, is under compression. So it's creating osteoclastic activity. So that osteoclastic activity creates the dehiscence. There's really no opportunity for osteoblastic activity on the leading edge. So when you look at this case here on the right, you can see that the lower left, now it's confusing, but the lower left lateral incisor here is dehisced to the facial, and the lower right lateral is dehisced from the lingual. And our literature is starting to, show this. I mean, this article is not an outlier. They're looking at non-extraction treatment. And it says non-extraction alignment with self-ligating brackets led to arch expansion associated with tipping of teeth. Expansion related to alignment resulted in horizontal and vertical bone loss at the incisors and mesiobuccal root of the first molars. Thinner tissue biotypes and more severe crowding before treatment increased the risk of buccal bone loss. There is more than just a few of these articles that have been published, and they all point in the same direction. That if you, whatever system you use, if you look at these post-treatment orthodontic cases, they show, a generalized pattern of root dehiscence. This is a slide from the 2016 annual periodontal conference. It was held in San Diego that year. And you can see here the key question that they're asking: does alveolar bone bend? There's a concept in orthodontics that as you move teeth slowly, that the alveolar housing moves with the tooth or flexes with the tooth. Well, clearly from all the dehiscence you're seeing on these images, the answer to that key question, does alveolar bone bend, is no. Here's a patient that came in with, you can see what this, her original malocclusion looked like. She obviously wanted the teeth retracted and the spaces closed. We suggested that she get arch augmentation prior to moving the teeth. She didn't want to do that, so what we said is what we'll do is we'll retract the teeth until we think we run into a problem, and then we'll stop. We'll take periodic cone beam CTs throughout treatment and see what happens. The lower we planned, what we did was we planned it for a fifth incisor, because there's no way you're going to retract and break those teeth with that alveolar housing. So here is her original sagittal slice of tooth number 9, and the progress, and here's the progress. This is where we stopped. And I'm not sure, I believe we probably went a little too far. But what's clear here is that alveolar housing did not change. The alveolar housing stayed where it was, and the tooth moved throughout the alveolar housing. And if you take a look from an axial view, you can see that slice, that yellow line represents this axial view. You see that these roots are dehisced through the facial cortical plate. And if you slice through here, it looks like they're surrounded by better bone. And that's just also a point here, is that you need to know where these slices are coming from. So if someone just shows you one axial view of this case, those roots look perfectly normal. But if you slice a little higher, then you see something else. Cone beam is not a static evaluation like a pan and a ceph. You're looking at multiple slices and kind of in your mind have to stitch them together to get, proper diagnosis and assessment of what's going on. So how accurate is cone beam CT? I mean, we have a whole body of literature now, and these are just the ones from the AJO that talk about the accuracy of cone beam CT. And I think you can break them up in really 2 categories, and I'm going to add a third. Some of the studies look at measurements. They take a measurement on a dry skull or of a open surgical site and compare it to the cone beam CT, and they look for discrepancies. The area I'm going to add is, does the cone beam CT accurately represent the anatomy of the alveolar housing? And then there is the ability to identify dehiscence or fenestration. This 0.6 millimeters of non-visible bone, we could spend a whole day talking about it, but let's just, for this talk today, assume that it's accurate. One of the discussion points are some of the early studies were taken on the 3D reconstruction. 3D reconstruction is really not accurate for measurements. Some of the studies just use the sagittal view, especially the ones from orthodontists, were oriented toward the sagittal view, so they only use the sagittal view. We know that you have to use multiple views to really determine, get a better assessment of what's going on, and I'll show you that in a minute. And then a lot of those studies were done on older machines. The newer machines have smaller voxel sizes, and it's like comparing an analog TV with a high-definition TV. The newer machines are just better. But we'll assume that the 0.6 millimeters is accurate, because it's probably more accurate than it is not. And I'm not sure it's really even that relevant to what we do as orthodontists, and I'll explain why. As far as the identifying the anatomy and shape and size of the alveolar housing. I don't think anybody has a problem with that. I think that it's pretty accurate. This is a slide I got from Gerald Nelson. This unfortunately was a 19-year-old girl that was tragically killed in an automobile accident. And this on the right is the dry skull section from the autopsy result, and on the left is a cone beam CT. You can't look at those two and say that the cone beam doesn't accurately represent what the alveolar housing looks like. In terms of dehiscence and fenestrations, if you look at those studies, you got to be kind of aware of who was doing the evaluation. Was it a dentist? Was it an orthodontist? Was it an oral maxillofacial radiologist? Was it a resident? Because if you're not used to looking at cone beam, you kind of look at it differently. There's a learning curve with it. And I think the most relevant part of these studies is that all these studies were done on naturally occurring dehiscence and fenestration. And I'll explain why that's important. When we look at teeth, there's a good percentage of our teeth that are going to have naturally occurring dehiscence and fenestration, but these are very small in magnitude. They're really, they're just like minor. So when you look at these, with the exception of an ectopically erupted tooth, the naturally occurring dehiscence, they're not that, significant in terms of trying to evaluate them at least from an orthodontic perspective. Let me explain what I mean by that. So if we look at this patient, this is pre-treatment, and we take a look at the lower axial view. This is halfway down the roots. Now, if you look at the first bicuspids, there's no question that this root is well centered within the alveolar housing. There's no issue with dehiscence or fenestration. But if you were to look at the anterior teeth, you may look at the the lower left cuspid, the lower right central, and the lower right cuspid and say, well, those look like they may be dehisced slightly. And this is probably where the 0.6 millimeters comes in. So, is there 0.6 millimeters of bone there around these teeth? Maybe, maybe not. I'm not sure it really matters for us orthodontically, because when we're talking about naturally occurring dehiscence compared to orthodontically induced dehiscence, we're really talking about two completely different things. So if a tooth is just slightly dehisced, or you're not sure and you see it looks like it's pretty much centered within the alveolar housing, it's probably okay. Because think about it, the tissue gets its blood supply from the bone. So when in this particular case that I just showed you, these are healthy teeth. So if our finished orthodontic results, look something like this, whether there's 0.6 millimeters of bone there or not, I'm not sure it really is that relevant. But when you look at something like this here, and this is clearly an orthodontic case, you see the fixed retainer, where the alveolar housing is behind the root of the tooth. Look at the apex. And there's, just some interceptal bone holding this tooth in. Is the 6.6 millimeters of bone really relevant here? And I don't think it is, because the magnitude of these significantly orthodontically dehisced and fenestrated teeth is different than what would occur naturally. If we assume that there is 0.6 millimeters of bone, what you hear constantly from, if you listen to the AAO this year, anytime they showed a dehisced tooth, they assumed that there was 0.6 millimeters of bone there. They would, you'd hear something like, well, studies show that there's 0.6 millimeters of non-visible bone. That doesn't mean that non-visible bone is surrounding that tooth. What that means is that if you look at the bone, there may be an additional 0.6 millimeters of bone, not root coverage. So I think there's a general misunderstanding, at least from what my interpretation of the way that these speakers were explaining the 0.6 millimeters of non-visible bone, as if anytime you see a dehiscence in a post-treatment orthodontic case, there's 0.6 millimeters of bone around the root, and that's not at all what it means. And here is a study by Sun where he showed that if the dehiscence was of severe, or, it was more, significant, of a higher magnitude, then it was easily identified, and the information was, it was a true dehiscence. And this, I believe, is in the category where we talk about orthodontically induced dehiscence. So this is a study by Capella and Nervina where they looked at non-extraction treatment. And you notice when you look at this, you see that it appears that half the root is outside of the alveolar housing from the sagittal view, but also from the axial view. If you see prior to treatment, these roots are centered within the alveolar housing, and there's a generalized dehiscence pattern associated with this type of treatment. And the positions of these teeth comport with the arch wires that are used, these broad formed, or whatever you want to call it, development arch wires. And in their conclusion, they said there was considerable loss of alveolar buccal bone following treatment. Well, these are just like that 20-year post-active orthodontic treatment. The dehiscence associated with this root looks identical to the dehiscence of these roots. The only difference between these two patients is this is a more generalized dehiscence pattern, where this is more localized. So what I hear from orthodontists occasionally is, well, okay, the cone beam probably does show dehiscence and fenestration post-treatment, but it doesn't matter, because if the periosteum is intact, then bone will fill in, okay? So this is, I believe this is where this kind of statement comes from. This is a patient that I treated. I extracted 2 upper bicuspids. This slice of tooth number 8 was taken 8 weeks post-active orthodontic treatment. Patient comes back 32 months later. We take another cone beam, and it appears that the bone has completely filled in. Okay, and this is an example of why you can't rely on a single slice, because from these 2 images, it appears that we don't have bone here, and 32 months later, the bone filled in nicely. And that's why you need to know, when you're looking at cone beam, where the slice is coming from. In this example here, we're slicing between the lower right, central, and lateral incisor, and we're looking at the interceptal bone there. So you need all this information to get your mindset as, where is this slice taken? Is this slice taken at the apex? Is this taken near the crowns, or what? For anterior teeth in general, you're looking at the axial and the sagittal views. The coronal view comes into play more so when you're looking at the lateral segments. Now, Ron asked me to talk about this case report. It wasn't an article; it was a case report from Bae in Korea. And what he did was he looked at a patient that was treated for bimaxillary protrusion with 4 bicuspid extractions. They took a cone beam right after active orthodontic treatment, and then they looked at it, and they noticed all these dehiscence associated with the anterior teeth from both axial and a sagittal view. So you see this is tooth number 9. You see the cortical plate comes down here and then just disappears from the sagittal view. 10 years later, the patient comes back and gets another cone beam, and it appears that tooth number 9 has nice bone surrounding it. And here's tooth number 9 from a sagittal view. Looks completely normal with proper bone around it. And if you compare the immediate post-active orthodontic slice of tooth number 9 with the 10-year post-active orthodontic treatment slice, maybe this tooth uprighted a little bit back into the housing, but clearly there was no bone shown on the sagittal view, and all of a sudden the bone filled in. So what does that actually mean? Well, when you look at that, it's pretty impressive. It's remarkable. You look at it and go, whoa, so it's okay to dehiss and bone will fill in. Well, that's not really what that showed. And if you look a little closer, the axial view they took immediately post-active orthodontic treatment was done on this approximate slice plane. And the reason I know that is because here you can see the sinuses, and what they're showing here as roots is actually mostly clinical crowns. Then when they did the 10-year post-treatment, they sliced on this kind of angle. Here they captured roots. There's no question those are roots. But when you compare the two, if you're trying to compare two axial views and you're taking them at not only different positions but different slice angles, they're absolutely meaningless. So you don't know whether these roots were because these are actually clinical crowns. And that's why, you know, you can't just look at the sagittal view and make a determination of really what happened there. Okay, so I'm going to go back to this case and explain this because I think it's important. So she finished her orthodontic treatment. We retracted the upper teeth. We took a cone beam 8 weeks post-treatment, and this is what tooth number 8 looked like. She comes back 32 months later. We take another cone beam. These are taken exactly the same slice angle, the same focal trough. Everything's the same, except for 32 months later, it looks like we have bone here all of a sudden. Here she is. When she started, she's got a Bolton discrepancy. She's missing her lower first molars. Our treatment plan was to extract 2 upper bicuspids and attempt to you know, unravel the lower crowding using the missing lower first molars. Today I'd probably do this differently, but that's what we did. Now, in 2013, we had cone beam, but we would only use cone beam when we thought it would make a difference in the terms of the treatment plan of the case. This case, we took a pan and set because, you know, to us this was pretty straightforward. And here's her Panorex. Here is a 19-month progress photos of her. She's being treated with incognito lingual appliances and traditional appliances on the lower. Now, notice that we have most of the extraction space closed. There is still a little space left to close, but the majority of the extraction space is already closed at this point. She's finished in a total of 26 months. There's her photos, and here is her 8-week post-treatment cone beam CT. When you look at her sagittal view of tooth number 8, you see that the bone on the palate kind of dies right here, and it looks like the majority of the root has dehisced through the palatal cortical plate. And just from a comparison standpoint, this is the reconstructed cephalometric x-ray from her. That does not even get you into the conversation. Okay, you can't look at individual teeth with a cephalometric x-ray and make an assessment of the bone that supports those teeth. She comes back 32 months later. Here's what she looks like. And we take another cone beam. And when you compare the two, it appears that the tooth number 8 bone has filled in there where it was absent in the sagittal view before. So what is going on? Was the periosteum still intact? Well, it had to be if bone filled in. But that's not the question. The question is, was there really a dehiscence on the lingual of that root? So here is the debond cone beam CT. If we slice through the center of that tooth, it produces a sagittal view like that. The height of this axial view is determined where you slice through the sagittal view. So this line here represents where this slice is taken. These are compensated for the position of the tooth. So we're looking straight down the long barrel of the root of that tooth. And here is the same thing, using the same line angles, and this is 32 months later, okay? So when you compare the two axial views and you look at the bone or on the lingual of this upper right central incisor, there's bone there. You don't really see a dehisced root. What you see is woven bone or immature bone. So the only difference really between these two views is that the cortical plate's more defined. It's mature. And that's what you have to be, one of the things you have to be very mindful of with cone beam is that we're moving teeth. So we're dealing with woven bone or immature bone. It's not going to read the same on a cone beam as mature bone. So with a pan and ceph, you can take a progress ceph, you can take a progress pan, and it's not going to make that much difference. But with a tooth that's in orthodontic treatment that's being moved, you're not going to get a good reading. You have to get, that tooth has to reach its final destination, and then you have to wait approximately 6 months so that the bone matures. So here, this is, 2.5 years later, you see there's a more defined cortical plate. But if you look closely here, you can see there's a cloudy area of bone there. So although it looked like it was dehisced from the sagittal view, you can't confirm that on the axial view. So there's probably no true dehiscence. And I'm gonna drill that down a little bit and go through it again. Here we have a dry skull, tooth number 26. You see this is a 3-wall defect. There's no buccal bone here, okay? So if you were to fill that with a tooth and then take a sagittal slice through the root of that tooth, depending on the manufacturer of the machine, that slice defaults at usually around 0.5 millimeter. So that slice is going to produce a sagittal view that looks like that. But what you don't know is how wide that facial defect is. So that's why you need the axial view. So the axial view tells you how wide that defect is. So as long as that defect is wider than this 0.5 millimeter slice, it's going to look exactly the same whether it's 0.6 millimeters or 6 millimeters, because the sagittal view is only a thin slice of what's there, and that's why you need both views. So in the case we just discussed, when we retracted those teeth, this is either immature bone, or this area here is either immature bone or maybe a small dehiscence. We're slicing right through that area, and that's how you get that sagittal view. And that's why you need multiple views to determine whether or not what you're seeing is a true dehiscence or not. And as I said before, I'm not sure really tiny dehiscence make that much difference in what we do orthodontically. The tissue is still able to get adequate blood supply. So when we look at that case report, and they kind of showed accurate sagittal views without the axial view to confirm, you don't know whether that root was dehisced to begin with. And here you can look at the axial view, and you see that this was the progress. It went 7.3, 7.2 millimeters, and 7.2 millimeters. So, there wasn't really much change other than the bone, became more mature, which looks different on a cone beam CT. So, how do we know if the periosteum is intact or not? Well, I think it's safe to assume that if the root is surrounded by bone completely, the periosteum is intact. And I also think it's reasonable to assume if half the root is sticking out of the alveolar housing, the periosteum is probably not intact. But the question, I think, really is not, is the periosteum intact or not? Because when we see the tissue recession associated with orthodontic treatment, you always see a clean root. The question really is, how far can the root be pushed out of the alveolar housing before the periosteum is no longer intact? And I don't believe we know that answer. And certainly, we as orthodontists, we dehisce slightly all the time. I always say cone beam doesn't tell you as much what to do as what not to do. All right, so we'll start here take questions. Let me turn.
Right now, I don't have anybody who has typed in a question to me.
Okay.
I have one for you. Well, actually, I have two. Let's say we have an extraction case, and you have a blocked out lower cuspid that may likely already have dehiscence. as you are retracting that cuspid back into the alveolar housing, would the bone form on the trailing edge, which would probably be the mesial surface, mesiofacial surface, as you talked about the bone not having any chance as we move the leading edge out of the alveolar housing, but if we're moving the tooth back into the alveolar housing on the trailing edge, is there a chance that periosteum or bone would reform?
From what I've seen, the answer is no. The defect seems to follow the tooth. Now, whether it's diminished a little bit, I think it depends on the angle you're pulling the tooth and how dehisced that root was when it started. But generally, if you think about it, if you have an ectopic cuspid and you pull it back, if it starts with a tissue defect, it ends with a tissue defect.
Okay.
And when you look at the cone beams on those, you know, they show the defect seems to follow the tooth.
Ron has typed in, how can you predict recovery of an apparent dehiscence?
Okay, so if the tooth, if we say we round trip a tooth and we push it out and pull it back in, if you don't leave it out there that long, it seems to go back to the normal bone tissue root relationship. If you leave it out there for an extended period of time, that changes. Time works against you when it comes to that. And that there is a recent article, I didn't include it in this talk, but there's a recent article about correcting gingival recession by attempting to reposition the tooth back into the alveolar housing. So assuming the alveolar housing is still there, if you push the tooth back in the alveolar housing, then that tooth has a better chance of having a proper gingival repair to it because the blood supply is there. If the further the root is away from the, let's say the interseptal bone, let's say a dehisced root, it's halfway away from the interseptal bone, it's difficult to get the blood supply to the tissue grafts. So the surgeon has to do, you know, more. It's more complex and it's less predictable.
Okay, I have another question from one of our members, Basil. Patients are always concerned about radiation exposure. Compared to Ceph and Pan, we know is less radiation. How does this CBCT unit compare to standard exposures of Pan and Ceph?
It's less. So we have almost every machine now has a low dose setting. And you know the low dose setting is less than the combination of the Pan and the Ceph. That was an argument before all the manufacturers put the low dose setting. Now the low dose settings are not going to be, the images are not going to be as crisp, but it's still way more information than you would get on a Pan and a Ceph.
Another question. I'm sure that you're looking at information, literature from other disciplines of dentistry. But if we see naturally occurring dehiscence, no orthodontic treatment at all, is there literature to document or verify that this tooth has a poor long-term prognosis? How concerned do we need to be about these dehiscences?
I don't think, when you say naturally occurring dehiscence, I assume you mean other than an ectopically erupted tooth.
Yeah. I
don't think they're that much of a concern. You know, I think you need to know about it before you start moving the teeth around. So if for example, you look at an axial view and you see that what may appear to be a dehiscence, which you're not, you know, it could be a dehiscence, it could have very thin bone that's not visible. But if your treatment plan includes expanding that tooth 2 or 3 millimeters when there's already no visible bone from a cone beam axial view, I think that's an important consideration, and that should be taken into account. And that's why, you know, it's not, you know, most people are in the middle, but you have, let's say you have an orthodontic group that is non-extraction at all costs. I don't think that's a valid treatment philosophy based on what we see in cone beam. It's not many of it, some of it's not detectable when you start looking at it from a pan and ceph perspective, but from a cone beam, you see it. Now, what happens is the tissue doesn't necessarily strip away immediately. It takes time for that to happen. When you start looking at these cases, and then if they're held with a bonded lingual retainer, which many of them are, then the tooth has nowhere to go. It doesn't have, relapse is probably a better option than you losing two-thirds of the attached tissue.
A few more questions have come in. If you were to install a CBCT machine at your office, do you need any special permit from the city, county, etc.?
Well, I can only talk about Maryland. Maryland requires you need to get it approved from the Department of the Environment, but it's the same as any X-ray machine,
okay.
And it's not a big deal.
Could you share with us how much these units that you like?
They've come down in cost quite a bit. It's not only the cost of the machine, but also the yearly fee that you pay for the service agreement. So, for instance, the iCat machine sells for approximately $130,000 if they discount it, $125,000. But the service fee per year for that machine is upwards between, depending on the service plan, it's between $5,000 and $9,000 per year. Carestream's machine is approximately the same price as the iCat Flex, and the service agreement I believe it's somewhere around $2,500 a year. The Periosteum machine comes with a 10-year warranty. There's no service agreement for that period of time. So think about 10 years of that service agreement. It's extremely expensive, especially when you have multiple offices.
We just got a message from John DiFrancesco. He says he's happy to discuss pricing with anyone interested in the Periosteum machine. Please feel free to reach out to him. You provided his contact information, and they are providing a special discount for attendees of this webinar today. So John would be a good contact for that.
Okay, so I guess it's a good thing I didn't mention the price of the Periosteum machine. So, but it's kind of like a dog. You buy the dog for $500. It's the cost of the dog is irrelevant for the maintenance of that dog and the vet bills and food and everything else. It's the same thing with a cone beam.
Yes. And one last question before we move on. How does your CBCT affect your referrals to your periodontist pre-post ortho ?
Well, the periodontists around here love us because we're not, we're mindful of the alveolar housing restrictions. It's really funny when you talk to periodontists, because when you talk to orthodontists, we think we're lining teeth up, we're creating healthier mouths. The periodontists don't share that opinion of orthodontists for the most part. I mean, I talk to a lot of periodontists, and they are constantly frustrated from seeing what we do orthodontically. Of course, their solution generally leans to orthodontic arch augmentation of some kind. But I find that when I send a patient for extractions, I don't get the questions, because what I do is I include screenshots of the 3D reconstruction. So I just assume that they look at that and go, oh, he must have a reason. I'll point out that there's a thin housing, and I always try to mention that I don't believe expansion is the solution for this case if I'm going to extract. I mean, and by the way, this is not about extraction, non-extraction. It's about keeping the tooth within the center of the alveolar housing to the best of our ability. Sometimes extractions can cause the tooth to pull out from the other side. So it's a balancing act.
Okay, Jeff, I think you're ready to move on to your next.
Okay. All right, so we talk about, we're going to adaptive resorption and retreatments. These kind of fit together. We're going to go back to that case we just looked at with the lady that had the upper buys taken out and the lower molars, and we retracted the teeth. We saw that, the during immediately post treatment, she had, let me get this up here, immediately post treatment, it appeared that she was dehisced, and then the bone filled in. We went over that. But these teeth, we extracted 2 upper bicuspids on this patient. We clearly retracted those upper incisors somewhere between, probably 5 millimeters, let's say. What happened to the excess bone that would have been on the facial? In other words, if we retracted these teeth, assuming these teeth were centered in the alveolar bone to begin with, what happened to all this extra? You would think there would be an extra 5 millimeters of facial alveolar bone there. What happened to it? Well, that's adaptive resorption. So here is a patient 15 years post-active orthodontic treatment. She came in because she had broken her lower fixed lingual retainer. We took a cone beam on her. This is the reconstructed pan and ceph for that patient. You notice she has a supernumerary tooth hiding behind the upper central, which we missed the first go around. And this is tooth number 26. You see how the tissue has dehisced from that root. Now, she reported to us that every time she went to the dentist would comment to her how beautiful her teeth were. And then she said after about 10 years, she noticed the tissue stripped away from that tooth, and she had a graft there, and that's the result of the graft. What I used to do prior to cone beam is if I saw something like this, I would assume that the tooth had moved outside of the alveolar housing. So I would put brackets back on. I would do some IPR and try to move the tooth or the tooth root back over the alveolar housing, thinking that the root would be more, better supported by bone. It was based on a cephalometric X-ray that has a focal trough that's so wide you can't look at an individual tooth. So if you take the same image and you reduce the focal trough, that's tooth number 26. There's really no opportunity to move that tooth lingually to get it into an area of better bone support. So here is adaptive resorption explained. These are all the images that actual images are going to be of the same patient's tooth number 26. So we have the sagittal, we have the coronal, and we have the axial views. We have the orthodontic force placed on, in this case, pushing the tooth buccally. The leading edge of that root dehisces through the facial cortical plate in this case. But what happens to this excess bone on the lingual? It resorbs, or it adaptively resorbs to comport with the new position of the tooth. So when you look at the sagittal view of this tooth, your initial impression is that the root is centered within the alveolar bone. But actually what happened was you have dehiscence on one side and adaptive resorption on the other. So when we look at that same tooth number 26, we can, with cone beam, we can actually take the slice and step back to see where the interseptal bone meets the tooth. And that's approximately where the bone ends. So for a periodontist to do a graft, and I think this is what Ron was asking, the distance between the interseptal bone and the edge of the root determine how successful that graft is going to be, because the blood supply comes from that bone. So in this case, there's no discussion about whether there's 0.6 millimeters of bone or not, or if the periosteum is intact, because we see that the root is exposed. From a coronal view, that's basically a panorex. It doesn't give you really any information about the dehiscence or fenestration. And I think the axial view is really the most telling. You have the root that's centered within the alveolar housing. You have the orthodontic force that creates the dehiscence of the leading edge of that root. However, some of those ligaments are still under tension. So you get a little bit of the flaring of that interseptal bone as the root is dehisced through the cortical plate. And then you have this excess bone on the lingual that adaptively resorbs to comport with the new position of the tooth. It's this axial view post-treatment that one of the orthodontic manufacturers was using as proof that their system uses such a light physiological force that causes bone modification as the arch is expanded, and there was no reason to extract teeth. So, and their rationale was, look, the root started centered within the alveolar housing in the beginning. Post-treatment, the root is still mostly centered within the alveolar housing. Well, when they were making those claims, nobody knew what they were looking at in the orthodontic world in terms of, or at least most people didn't know what they were looking at in terms of a cone beam CT. Well, then someone, at some point we realized that's not what it showed at all. It showed adaptive resorption on the lingual and root dehiscence on the facial. And since then, they've taken every one of these axial views off of their website. But I find it still remarkable that they still make exactly the same claims. So, when you see a root that's, this root's probably a third of the way dehisced, I don't believe that, when you see a dehiscence of this magnitude, there's no way of really knowing if the periosteum is still intact or not, but I would assume that it's compromised. You don't know until the tissue strips away, and then if the tissue strips away, then it's clear that it wasn't. If we go back to the Capella and Nervina study, you see that these roots were pushed out of the alveolar housing from both the axial and the sagittal view, but you can also tell that this image was taken right after active orthodontic treatment because there was no adaptive resorption yet. Over time, these teeth would have looked like this. And the one thing is, if you can get an image of the tooth prior to the adaptive resorption, you can kind of get an idea how much it was pushed out or how much it was dehisced more easily. Once it's adaptively resorbed, the root always kind of looks centered. So you have to kind of look a little harder to see how much. You have to look at the interceptal bone and see where it was. I found this study from 2002 that was published in the AAJO by Dr. Sarakaya, and what they were showing is that they would retract lower incisors, and the alveolar bone, the alveolar housing was reduced, and they called it labial plate remodeling. And that's adaptive resorption. It doesn't matter whether you push the teeth to the buccal or the lingual. The alveolar process, if you think about it, is there solely to support the root of the tooth. If the tooth is removed, especially when you're talking about the areas of the mouth that have thin alveolar housings, thin cortical plates, like the lower anterior region, that adaptive resorption occurs at a faster rate. I think this is worth mentioning. I've been to several talks where the speaker will say something like, a slow-growing cyst can dramatically expand the dense buccal and lingual cortical plates. So that if a cyst is capable of expanding bone, so is a light orthodontic force. And the first time I heard this, I thought about it, and it just didn't sound right to me, but I never, I had to think about it a little bit more. And I realized, a cyst, maybe I was sleeping during that lecture in dental school, but I don't believe a cyst has a periodontal ligament. And that's where the osteoclastic and osteoblastic activity comes from. So to say you can treat every case non-extraction and expand arches at will because of some cysts can expand bone, I think just doesn't make any sense, but I think it's worth mentioning. But I think the best argument against all this talk in the orthodontic specialty arena that, there's no reason to extract teeth anymore, we can use a light physiological force, and as long as we do that, the bone will modify as the tooth is expanded, is an ectopically erupted tooth. This is a 39-year-old female patient. This cuspid erupted ectopically because it came in after the lateral incisor and the first bite. Whenever you see an ectopically erupted tooth, those ectopically erupted teeth never have the bone coverage of a tooth that erupts within the center of the trough. It just doesn't happen. So when you look at this case and you look at this ectopically erupted tooth, you see the magnitude of dehiscence associated with that cuspid. I believe it's the epitome of arrogance to say that my mechanical system has such a light physiological force that it modifies the bone as the arch is decrowded or expanded. If Mother Nature can't do it, to think that a mechanical, man-made system is going to do a better job, to me, it just doesn't, add up. This is a case 24 years post-active orthodontic treatment. She was missing her upper left lateral incisor, and she has a PEG upper right incisor with a veneer or bonding or something like that on it. You wouldn't expect the alveolar housing for the cuspid to be the same size and shape as the PEG lateral. And I don't remember the case from 24 years ago, but based on her fixed retainer, I would assume that there wasn't much space to close, if any, went for the erupted cuspid. The cuspid must have erupted within the center of the trough, and we didn't have to close very much space. The space must have been between the central incisors. Otherwise, we would have incorporated the fixed retainer into the cuspid. So when you look at it from an axial view, you see just that. The width of the alveolar housing for the cuspid is vastly different than the alveolar housing from the lateral incisor. There's a concept in orthodontics that if you well, let me try it this way. If it doesn't work out, we'll retreat the case, and there's no consequence to pay. And I'm sorry to have to tell you that is not the case. Here's a case that a colleague from Florida sent me. He only sent me these two images. This was not his patient, but there's a lot you can tell from these two images. One, first of all, I would just assume that this incisor is the lower right central with the frenum involvement. You can also see the attachments on these teeth. This patient's being treated with aligners. You notice that there's a washboard gingival appearance or blanching of the tissue, that these incisors still aren't completely aligned, and that based on the adaptive resorption of the alveolar housing, this patient has been in active orthodontic treatment with aligners for an excessive period of time. Now to try to fix this or pivot and go to some other method to try to get the tooth back centered over the alveolar housing after the adaptive resorption, it's much more complex if it's even possible at all. Compared to this patient here who has more of an acute dehiscence. He started chewing on plastic water bottle caps. He torqued his tooth around his fixed retainer. Why the fixed retainer didn't break, I have no idea, but this is his dentist picked up on it, sent them back, and in this particular case, the alveolar housing had not adaptively resorbed to the point where it was, we were successfully able to move this root back within the alveolar housing. So here is what he looked like. He actually torqued his, this is it's confusing, but this is the lower left lateral, and this is the lower right lateral. He torqued them in different directions around. I think it was related to the fixed retainer and the parafunctional habit he had. But we were able to take that root and move it back within the alveolar housing using customized appliances with we told the digital lab exactly how much torque we wanted. In this case, we used incognito linguals, and you can see both from an axial and a sagittal view how we got the tooth back into place. Now here's what you won't see from orthodontically induced dehiscence. What you won't see is, if you see the dehiscence post-active orthodontic treatment, what you won't see is cortical bone filling in and looking something like that. That's something I've looked at thousands of these post orthodontic treatment cone beam CTs, and I have never seen anything that looks like this. So here is the upper arch. Now, if we over expand the incisors, the interseptal bone that's still under tension with the periodontal ligament will kind of flare the bone. It's like a trailing bone. And then you would get a adaptive resorption of the bone to comport with the newly orthodontically repositioned teeth. Okay. So are there any examples of this? Well, it actually turns out there are, believe it or not. And it's something called an anterior growth guidance appliance. These are appliances that are used by general dentists. Mostly they claim everything. They'll fix anything that's wrong with you. But they basically claim that that little plastic pad presses on the incisive nerve and causes growth of the midface. And the idea is it increases the oral volume so that if you have an airway issue, it helps. Okay, and that's what these appliances do. Now this leads us to the actual kind of topic of this this talk today, and that's what is the role of the alveolar housing now that we can visualize it for the first time. A Pan and Ceph are not capable of looking at the alveolar housing for an individual tooth. Okay, forget that. That doesn't happen. When you're looking at a Ceph and you're tracing the bone around an incisor, you don't know if that bone that you're tracing is part of the cuspid or incisor. You're looking at the most facial and the most lingual cortical plates. You don't know if you're tracing the clinical crown of the lateral, central. Sometimes it is actually the cuspid. You can't look at an individual tooth. And I think we'll all agree that all men are created equal in God's eyes. However, bone is not. Bone not only varies between different individuals, it can vary in different segments of the same individual's arch, especially when we're talking about the alveolar housing. And the only way you're going to know about this is if you look at it from a cone beam CT. There's no other device or tool that we have that can give you this information. So these are two different patients. Both have similar orthodontic problems. They have different alveolar housings. If you understand the difference between these two images, you got the whole point of the talk today. Because once you can recognize this and visualize the difference in alveolar housings, you changes what you do as an orthodontist. Are you going to treat this patient here on the right the same as this patient on the left? Now, with the lower arch, especially the lower anteriors, you have thin and thinner. You don't have robust alveolar housings. Like in this patient here, these are two patients, both need retraction of upper incisors. This patient, there's no problem. He has an extremely robust alveolar housing. With this patient, 13 years old, has a narrow alveolar housing that's approximately the same width as the incisor. Anywhere you move this tooth is going to have a negative consequence on the alveolar housing relationship with the root. So I guess if there was a mission statement associated with alveolar-focused orthodontics, it would be attempt to keep the roots reasonably contained within the alveolar housing. And as I said before, cone beam doesn't necessarily tell you what to do as much as it tells you what not to do. So here's a retreatment case. You can see from the axial view and the sagittal view of the lateral incisor. Knowing that information probably would change what you do orthodontically. Here, just as a comparison, this is untreated, a patient approximately the same age. You see the upper teeth are well centered within the alveolar housing. Would you be able to appreciate this relationship from a Pan and a Ceph? And if we could reconstruct the Pan and the Ceph, the answer is no. It doesn't give you that information. I love showing this diagram to residents and asking them, is this acceptable treatment? Can you advance those lower incisors to correct the overjet? And of course they say no, nobody has that kind of alveolar real estate to accommodate that kind of movement. But when you look at this, this is a gallery case. This is a case that they're actually proud of. This is, and it's not a knock on Embrace. I think Embrace is a brilliant lingual system. But the fact that they would show this as one of their cases that they're proud of just makes no sense to me. If you look at these cuspids, notice there's some composite there, there's probably some root exposure associated with those teeth. You have two ectopic cuspids, and their genius solution to treat this case is to advance the four incisors to align with ectopically erupted cuspids. I mean, in whose world does that make sense? They do say that they did the recommended IPR was performed. I'll leave that to you to decide. But they're taking these lower incisors, and this is an asymmetrical ectopic cuspid, but they're advancing these incisors, and at the same time, they're getting torqued, which makes it worse, to these ectopically positioned cuspids. Nobody or no Homo sapien has that kind of alveolar real estate. They would have to have done surgically facilitated orthodontics, or whatever you want to call it. It goes by different names: pre-orthodontic augmentation, Wilcodontics. But they would have to add bone there if they're going to do that kind of tooth movement. But what about this? We're always concerned about anchorage. We assume that, we're always trying to minimize the forward movement of the lateral segments when we try to retract. Is this acceptable treatment? Well, I think it depends on the alveolar housing. We have 3 patients, all need retraction and uprighting of the upper incisors. This patient with the more robust alveolar housing is certainly going to do better than this patient. If we take a look at this last patient here on the left, it's an adult female patient. Her chief complaint is bimaxillary protrusion of her anterior teeth. Back in 2014, we were still thinking pan and cephs. This particular patient walked in. I was working that day with another orthodontist, and we looked at the ceph and we said, let's get a cone beam. So we put the braces on, took a cone beam, and we looked at tooth number 9, and we're saying, well, wait a second, do we actually want to extract 4 first bis? These cases that are bimax are usually treated with maximum anchorage. And we really, I think we had a valid discussion about, traditionally these cases are treated with 4 bis, they're maximum anchorage. They seem to turn out okay. So why would we change anything? On the other hand, now that we can visualize the alveolar housing, does that change what we do? And those bimaxillary cases that are treated with 4 bis, when they come back 10, 15 years later, they don't all look so fantastic. So we compromised in this particular case, and we decided to pull second bicuspids, which I'm not a big fan of. I probably wouldn't do that today, but that's what we did then. She finishes in 19 months. This is what she looks like. She was happy with the result. When you compare it to the original protrusion, there was definitely some resolution to the bimaxillary protrusion. But when you look at it on individual tooth basis, tooth number 9, and you compare, we did retract and upright, but then again, the alveolar housing kind of stays where it is, and you see we have some fenestration of that root. Now, do I think that's going to create a clinical problem? I don't. I think that's reasonable amount of dehiscence and fenestration that we do on a daily basis as orthodontists that, never becomes, or rarely, I'm not going to say never, rarely becomes an issue. But what if we would have used maximum anchorage on this case? Well, I did that on another case. So in this particular case, this is his tooth number 9. We retracted that with maximum anchorage, and this 29-year-old developed tissue dehiscence during treatment. In other words, he started with normal gingival contours, and as we retracted and uprighted his teeth, the tissue dehisced. He had a similar, it doesn't look like here, but he had a very similar looking alveolar housing to begin with. Now, I occasionally will talk at some of our county meetings where the general dentists, they come to hear about, orthodontics, and I'll hear somebody, one of them will come over to me after the meeting and like, hey, Jeff, listen, I took the weekend course for aligners, and I'm going to just do my simple case. I just want to do simple cases. I'm going to send you the complex cases, so don't worry. In my generation, we're hardwired to appreciate the 1 or 2 cases we get every 20 years from these guys. But one of these days, I'm just going to lose it, I think. Anyway, so this case came in from another orthodontist who is very cone beam CT oriented, and she looked at the case. She originally estimated 3 to 4 months to treat this case. It's a retreatment. From the clinical photos, it doesn't look like any big deal. She looked at the alignment of the incisors and she said, you know, this looks like all related to torque. And she knew that before you start torquing, you should at least look at a cone beam to see what the alveolar housing looks like. So she sent the patient over. We took a cone beam. This is the reconstructed pan and ceph. Kind of a lame excuse for a pan and ceph, but it's not that important for what we're trying to discuss here. And here is, you can see where we're slicing. We're going right down the long barrel of the root of the lower incisors, and halfway, this axial view is halfway down the root. And you notice from the alveolar housing that these roots actually don't even fit into the alveolar housing. So where you may have a tendency to IPR lower 3 to 3, that'll probably make it worse. You can't IPR a root. You know, they just don't fit. There's not enough real estate to fit these roots in. So I guess you could IPR the lateral segments, but then you're compromising a nice class 1 relationship. So things that look very, very simple on the surface, you know, kind of like when I started, when I said, you know, you're looking at the clinical crowns, and as you add more information, all of a sudden things get complex, more complex. And that's the first hint or clue as to why orthodontics is going to return back to the specialty arena where it belongs. Here's another case. This patient, this is the 3rd time in braces. First time she had 4 buys taken out. Second time she had tooth number 25 taken out. We're not touching her lower arch, her upper arch. We're only treating her lower. Okay, she's already got 3 teeth out. You're kind of limited in options here. You know, you're kind of limited in, as far as I can tell, to doing IPR. Well, you look at the pan and ceph, you know, it doesn't really give you any information of, you know, what the real problem is here. And when you take a look at the cone beam CT, and you look at the area where the lower incisor was extracted, you see that that patient only has a little under 1.5 millimeters of alveolar bone where those teeth have tipped into. You see the hourglass of the alveolar housing. And I believe that's a result of poor extraction mechanics. If we have time, we'll go over that. But if you look at the lower arch, and you look at the tipping of this lower left central incisor, without knowing that information, you probably put the bracket on and try to upright this root. You're trying to squeeze that root into an area where it won't go. So in this particular case, we're going to compensate the position of this bracket so it does not take the root and tip it into that hourglass area of the alveolar housing. You know, so, you know, in this case, we're not going to parallel the roots. But let me ask you another question. You know, how relevant is the 0.6 millimeters of non-visible bone in a case like this? It generally is not that relevant in any of our cases, although you hear it all the time. This is another case. This is a 22-year-old patient. She lost her upper right first molar, and you can see that there's like, you know, that there's some been tipping of the molar into that space. There's the 3D reconstruction. And if we take a look at the area we're talking about, do you open that space orthodontically? Do you close it? Or do you not touch it? Leave it where it is? Well, let's take a look. We see from the axial view that the width of that edentulous area is just under 9 millimeters. The width of that tooth is almost 14 millimeters. So if you were to try to close that space, and I assume you would try to correct the rotation of that molar, you're you're almost 5 millimeters over the width of that alveolar housing. If you were to distalize that tooth, there's no, you're going to run out of bone, because if you try to push it back, you see there's no additional alveolar bone. There's not unlimited supply of bone as you distalize. There's a limit to our orthodontic tooth movement in all dimensions. So something that, you know, appears to be pretty straightforward and simple, once you start looking down at it with a, you know, in terms of alveolar housings, it becomes, all of a sudden, it becomes more complex. If you want, we can have additional questions now or move on to cone beam CT and PAN.
I'm sorry, we do have some questions.
Okay.
How effective would pre-treatment grafting a la Orthodontics to reduce dehiscence?
I think it's effective. You know, I don't, the problem I see with it is convincing the patients to do it. It's expensive. We have a guy here in Baltimore, Dr. Murphy, that is you know, is you know, trained in that. He's very good at it. But, you know, if I send 3 patients over there, maybe 1 will do it. And I think it's difficult to get long-term data, because you're not going to, you know, radiographically you see the bone. So right after the surgery, it's all packed in, and then over time, it tends to like diminish a little bit. But you're not going to go back and pull, you know, retract the tissue and actually look what histology happened. What's the relationship? But I mean, it seems to be a legitimate thing to do. And, you know, compared to what? There's not a lot of options. In a case where you're just to align the tooth, you're going to dehiss, that may be the only option.
If we see periodontists doing bone grafting for volume so that they can put implants in, would they be able to do pre-treatment grafting to solve some of these defect issues similar to that last case you showed?
I think so. I think the grafting is more predictable in different dimensions, like in height versus width, or width versus height. I mean, I think that it's right now, there's nothing that I'm aware of that says don't do it.
Okay.
Yeah.
Jose Castillo is saying, are you concerned about round tripping? If you get acute adaptive resorption during round tripping, you should be able to recover the bone when you return the tooth to your original position. But if round tripping takes longer than 6 months, do you expect to get permanent dehiscence?
Well, that's a good question. He's paying attention for sure. If you round trip and you leave them out there for excessive period of time, it seems to be a function of the thickness of the cortical plate. It's not as mission critical on the upper. You have a little more time for you know, in terms of round tripping. You can leave the teeth out there a little longer on the upper and not have the consequences you would on the lower. The patients with the hyperdivergent patterns tend to have the thinnest alveolar housings and the thinnest cortical plates. So those patients adaptively resorb, especially in the lower anterior region, quicker. So the round tripping of the lower incisors is generally not a problem as long as you bring them right back in and don't leave them out there for several months. But after a while, they're going to adaptively resorb, and then you're going to bring them back to a alveolar housing that's diminished.
We have another question relating to the age. Do these bony issues apply to teens, or is it kind of similar? Like we get away with more in teens than we can in our adults?
I think as you age, your alveolar housing seems to shrink. So the teens start with generally they start with a wider alveolar housing than a patient that's older. So you have, you know, it's, if you're looking at limitations of tooth movement or orthodontic tooth movement, then you're looking at the thickness of the alveolar housing, and the younger patients seem to have more of it.
Okay. That seems to be all the questions for now, Jeff, if you want to move
Okay.
on to the next section.
Okay, so when we talk about cone beam CT versus cephalometrics, there's really, you can put orthodontists that are cone beam CT oriented into kind of two camps, let's say. You have the ones that are using the 3D reconstruction and trying to duplicate the cephalometric analysis using the 3D reconstruction to do what, something like a 3D cephalometric analysis. Okay? Then you have another camp which is saying, look, the cephalometric measurements aren't that relevant, because if I'm going to look at a lower incisor to mandibular plane angle, I don't care if the average is 92 degrees. I'm going to keep that lower incisor within the alveolar housing the best I can based on looking at the individual alveolar housing. So there's like a divide. And right now, I believe that the predominant view is to try to create a 3D cephalometric analysis versus, looking at individual teeth and their supporting structure and then kind of doing away with the cephalometric analysis. I think it's important to understand cephalometrics, but also understand that cone beam gives you more information, and what you do with that information, I think, is the more important thing. So let's look at a case. This is a 19-year-old female patient. This is a reconstructed pan and ceph from her cone beam CT. And just by the way, if you're thinking about purchasing a cone beam CT, you don't need the cephalometric attachment. It's no reason for it. You can take the cone beam and recreate the pan and ceph without the cephalometric attachment. So if you'll notice, the ICAT machines don't sell the cephalometric attachments. Some of the other machines sell the cephalometric attachments. It's not necessary to purchase that. So in this particular case, if you were to describe this patient's malocclusion, you would say she's a class 1 dental, she's class 2 skeletal, she's retrognathic mandible, she's bimax, she's got slight crowding in both arches, she's open bite, she has poor lip competency, she's a convex soft tissue profile, she has slight tongue thrusting, she's dolichocephalic or hyperdivergent, and she has a slightly gummy smile. Based on a cephalometric analysis, your treatment approach or your treatment strategies will probably start with extraction of lower bias, decompensate the position, and do orthognathic surgery. If the patient refused orthognathic surgery based on the hyperdivergent pattern, the open bite, the convex profile, you would probably pull 4 first bicuspids and maybe use TADs to help intrude the molars to close the bite. You could take a non-extraction approach with IPR and maybe use TADs to intrude the molars, or you could do a non-extraction approach with IPR and orthognathic surgery. And of course, there's always the option to do nothing. And I would suggest, based on the cephalometric analysis, your first choice is going to be the top one, and your second choice is going to be the second from the top. But if you looked at this patient from a cone beam CT perspective or alveolar housing perspective, I think the last thing you're going to want to do is extract teeth on that lower arch. So knowing that how thin that alveolar housing is, probably your first choice would be the bottom, and then the second choice would be the second to the bottom. And that's what Hoang and Nelson showed in their study, where they looked at different skeletal patterns, and they related the thickness of the alveolar and the anatomy of the alveolar housing based on these skeletal patterns. And the dolichocephalic patients, they just have the narrowest alveolar housings, and that's what they showed. And you could see in this image here that you see how after treatment, the root was pushed out of the alveolar housing. Dr. Andrews did not have a cone beam CT when he did a 6 keys of normal occlusion. And I think if he did, key number 3 would probably have to change, because the torque or the inclination of the clinical crown, I believe, should be based on the alveolar housing anatomy and not on a statistical average. So this is a 13-year-old young man. He's got some protrusion. He's got Bolton. He's mostly class 1. You see the bimaxillary protrusion associated with his teeth. Notice he has some supernumerary teeth, you know, sitting around there. Here's his 3D reconstruction. And here is sagittal view of tooth number 9. You notice the alveolar housing for tooth number 9 is very narrow and thin. We can take the DICOM file that's produced from the cone beam CT, and we can merge it with the STL file from the digital scanner, and it can create a 3D model where we can simulate treatment in a virtual environment. Now, the problem with doing these types of simulations is this bone housing, while it's accurate, is static. It doesn't show the interseptal bone changes as you move the tooth, but it gives you an idea of what movements you do and the results. So, you know, it's kind of goes into that argument. Cone beam tells you more what not to do than what to do. So I asked the guys at Brius, which is a lingual system that uses this technology, to set this case up in 2 ways. I asked them to set it up based on Andrew's 6 keys of normal occlusion, and this is the result. So if you look at the fenestrations of those roots, that's exactly what you would predict would happen because of the anatomy of the alveolar housing for those upper teeth. So, you know, that's probably not that much of a clinical problem. This is a different patient, but this is probably what it would end up looking like. But then you look down here at these lower anterior teeth, and you see that they're almost halfway out of the alveolar housing. And I believe that this potentially could be more of a problematic. I also asked them to set it up based on the alveolar housing anatomy, and they did that as well. And you notice there's no fenestrations associated with these upper teeth. And if you compare the two, you know, cosmetically, is this one as good as this one from a clinical crown perspective? I mean, to me, it looks about the same. If this is one of your loved ones, I'm pretty sure you're going to want the result on the right. So when we set, you know, cases up, I mean, this, to me, this is an argument for customized appliances, because the torques should vary based on the anatomy of the alveolar housing. And that's actually the second clue as to why orthodontics should return back to the specialty arena where it belongs. Here's a very similar case, just another patient. He's a teenager. I don't know exactly how old. I don't remember. Bolt discrepancy, just like the other one. He's bimaxillary protrusive. When you look at his cone beam CT and you look at his upper alveolar housing, you notice that he has more real estate, which means you can maneuver that tooth much more than the previous patient. And that's really what, you know, what it's all about. If you can't visualize it, you're not mindful of it. Cone beam CT, you know, lets you visualize this thing that we couldn't see before. Ceph pan analysis, it implies that all the alveolar housings are the same size and shape, and they're just not. That's not the case. This is a case that was referred to us by a periodontist. One of the periodontists in our area. He had completed initial therapy, and he sent the patient over, and he said, you know, consider extraction of upper bias. Her chief complaint is the protrusion of her upper teeth. This is the reconstructed pan and ceph from her cone beam CT, and you can see there's some issues with the bone here, but she had perio clearance. I have confidence in the periodontist to send the case over. Based on a pan and ceph, I wouldn't hesitate to pull 2 upper bias and retract those teeth. When you look at it from alveolar housing perspective, and you look at the upper central incisor from both a sagittal and an axial view, you see that half of that root is already out of the alveolar housing. The last thing you probably want to do in this patient is retract those teeth. So we're on a ceph pan analysis, it looks completely fine. You're not even aware of it. When you start looking at it from cone beam CT perspective, everything starts to change all of a sudden. This is a case I pulled off the Global Invisalign Gallery. It was a case of a 33-year-old female patient. She was treated with 4 first bicuspid extractions. She was treated, it took 25 months to treat her, and she had 77 upper trays and 77 lower trays. So you can look at the clinical photos and look at the tissue up here and down here of the pre-treatment. You notice, look what's happening with the cuspids. You see the blanching of the tissue, and then when we get to the finished result, you notice the washboard gingival appearance and the blanching of the tissue here. That's an indication that there's possible dehiscence. When you look at the Panorex, it doesn't tell you anything. And when you take a look at this ceph, these are very high quality cephs. And you look at it, you can see the outlines of these teeth, of these roots outside of the alveolar housings. So they look, if you trace them, they look like this. So what they did here, it was they set these teeth to average torques and ignored the anatomy of the underlying alveolar housing. You know, and just, you know, what they did here was, you know, after adaptive resorption, this is going to look exactly like this, maybe even worse, because it appears that she started with very thin housings to begin with. So, you know, once you start looking at these things from cone beam CT, everything starts to change. You can also simulate surgery using the 3D reconstruction. This patient here was a retreatment. I didn't do the treatment the first time, but you can take the cone beam, you can modify, you can simulate different positions of the upper and lower jaws to simulate surgery, and you can do it. And once you have that virtual simulation, you can rotate and spin this around just like any other 3D reconstruction. Gives you good, you know, idea of what, you know, adjustments you need to do prior to surgery. So you can see here is the virtual simulation we did using the machine, and here is the actual surgical result from the coronal view, and here's what his finished occlusion looked like, and here's what he looks like facially. So it's just, you know, it's just another thing you can do fairly easily without having to do models when you look at these surgical cases. Bob, do you think we have time to go through extraction mechanics?
Oh yes, I think so. If anyone has a problem, they can drop off.
Okay. Okay, so when you start looking at extractions and mechanics that we use orthodontically, really we're looking at what happens to the alveolar housings if you delay closure of the extraction space. You can see here that the extraction of this bicuspid, there's diminished alveolar housing. There's adaptive resorption that can occur within the extraction site itself, especially when we talk about the lower anterior region. I don't believe that we have the luxury of waiting until to close extraction space. And some of the residency programs are taught to work up through a wire sequence starting at point, you know, like a 0.06 NiTi, and work it up to 1825 steel or to a 1925 steel before they start space closing mechanics. I think that's a mistake because you lose alveolar housing size by delaying it. The alveolar housing starts to resorb, especially when we talk about the lower anterior region. Here's another case from the Invisalign Global Gallery. You know, why this doctor is trying to correct the class 3 with extraction of 2 lower first bicuspids, but you notice that the extraction site has completely resorbed. Now trying to close this space, you're going to get tipping, you're going to relapse of that extraction site. It's just not the same bone that you would have had if you moved your teeth into the extraction site quickly. Our protocol is whenever a patient has extractions, we'd like them to come back within 5 to 7 days after the extractions so we can start space closure. We, in our practice, we will not do aligners on extraction cases. We've run into too much trouble with it. Maybe other people are just better at it than we are, but we will not ever do anything that has to do with extraction and aligners. I don't think they work well together. This is a 39-year-old patient. We decided to treat him with 4 first bicuspid extractions, and these are the mechanics that we currently use. We pull, we get them in, usually within a week after the extractions. We pull from both the buccal and the lingual, and we find that we can close extraction space for first bicuspids usually within 3 months. Also, by pulling from both the buccal and lingual, it keeps the tooth centered within the alveolar housing better. You don't get the rotational effects of the parachain that you would normally if you just pull from one side, and it just keeps things cleaner, I think. This is another case from the Global Invisalign Gallery where they extracted a lower left central incisor. You see the dark triangle that was created. And by the way, I'm not picking on Invisalign. They just have a lot of cases on their global gallery, some good and some not so good. But it's kind of the low-lying fruit in looking for examples. There are tons of cases there, and they're usually well documented, so you can get a lot of information from there. When we close lower incisor extraction space, we also pull from the facial and the lingual at the same time. You can see this is approximately a full tooth, and you can see that in 4 weeks we have the majority of that space closed. We find that lower extraction space generally closes within 2 months. And here you can see this is a different case. This is 2 months into it. You notice there's no dark triangle. The tissue was a little inflamed, but it's closed properly. This is a really interesting article that was published last year at AJO. It came out of Chapel Hill, where they talk about orthodontically closing a space before the tooth is extracted. So what they're really doing is trying to avoid the dark triangle. So they're orthodontically closing the space, kind of pushing the tooth out of the arch, and then when the space is smaller, then they go ahead and extract the tooth. By doing that, it's less space to close, which doesn't allow the bone to resorb as quickly. So they avoid the dark triangle. One thing they said is they always pushed out to the lingual, and I'm not sure why. To me, it wasn't clear. If anybody knows why they only push to the lingual, we do it, and we push out to the facial or the lingual. It doesn't matter. We do it both ways. Here's one of our cases. The parachain was running between these two teeth. They took it off for the photo, but we have a little spring to push the tooth out to the lingual. You notice here that the root started slightly dehisced. Here she is right before we sent her for the extraction of lower incisor. She's being treated with incognito on the upper, and the space closed in approximately 2 months. You notice this is an adult patient. Even though you see a little tissue recession, she started with tissue recession on that tooth. You can see here, she has a little clefting of the bone there. In this case, look at the date. You see March 11th, 2020. We're using a Brius lingual system here. You see the tissue dehiscence associated with tooth number 25. Notice that these were installed right before we were shut down for elective procedures by our governor in the state of Maryland. So in this particular case, we knew that tooth number 25 was dehisced. You can look at it right here, and it's confirmed by looking at the tissue recession associated with that tooth. Notice that also there's not enough room in the alveolar housing. You kind of even push that tooth back in. You'd have to expand everything. So our plan is to extract that tooth, but we didn't know when she would be able to get the tooth extracted. You can see that's kind of where the cortical plates are. So we put the appliances on. You can see them here, and we put some buttons on the facial to help close the space. And then she ended up getting the tooth taken out on April 1st, 2020. And you could see that, the facial cortical plate is missing here. You can see the defect in the surgical wound. She took selfies of these and she sent them over by email. When you have a portion of the buccal bone or the cortical plate missing, and you delay extraction space closure on a lower incisor, it can easily become a disaster. This is a liner case where they lost, maybe during the extraction, I'm not sure how they lost the facial cortical bone, but they delayed the extraction site space closure, and this is what resulted. Here she is after 1 week. You see the clefting here. And here she is about 2 weeks later, 3 weeks later. Here she is, a month after, 2 months into treatment. Notice the tissue here got really red and swollen. Here things are starting to look a little better. It's July 15th, 2020. And she came in on the 12th, and she's pretty much done. Now you notice that we still have a little triangle here, but considering she started with bone that was missing, to me that doesn't look too bad. She still has some papilla. You can see it here as well. Yeah, here you can see it better. You can see the papilla still there. This was the virtual simulation based on the setup. Here's another case. This is a case that's being treated with incognito linguals. We free floated the space closure by pulling from buccal and lingual, and here's after 9 months. We got the space substantially closed. I'm not a big fan of round tripping teeth, so I'd rather bypass them, make room, then we added the brackets and attach them to the arch wire. So we started by I started by making like a opinion that cone beam CT and alveolar focused orthodontics will return orthodontics back to the specialty arena where it belongs, regardless of whether or not orthodontics participate in that movement. When you look at a case like this, and whether you have a positive or negative opinion of this case, how will this case be evaluated 5 or 10 years from now? Okay, orthodontists do not practice in a vacuum. Okay, our patients don't only see us; they see general dentists, they see oral surgeons, they see periodontists. In 5 or 10 years from now, is this case going to be evaluated by a pan and a ceph, or is it going to be evaluated by a cone beam CT? And I would suggest that a lot of the general dentists, when they have to replace their digital pans, are going to cone beam CT. In our community in Maryland, most of the periodontists and oral surgeons already have cone beam. When a general dentist treats a case and just is concerned about the mechanical alignment of the clinical crowns, patients jump from general dentist to general dentist. They don't stay with the same general dentist their entire life anymore. It's unusual. At some point, that patient is either going to get a cone beam from his dentist that did his aligner treatment, or he's going to get a cone beam from another dentist. And with most people, most dentists, when they first start with cone beam, they start sending them out to oral maxillofacial radiologists. And when they look at these cases that were overexpanded, they all kind of have the same appearance. There's a generalized dehiscence pattern because of a magnitude that's not, that's kind of not natural. You see the dehiscence of the roots from first bi to first bi, or from cuspid to cuspid. And once you've seen one of these, they all look pretty much the same. Is that dentist obligated to make the patient aware of the positions of those roots post-orthodontic treatment, even in the absence of tissue dehiscence. If the dentist that takes the cone beam isn't the one that did the fast braces or the 6-month smiles, he's probably going to say something. He's probably going to refer the patient to the periodontist. And I know what you're saying. You're saying, well, wait a second, Jeff. Standard of care is only what is relevant at the time the treatment was done. What would a reasonable person do at that particular time? And right now, the standard of care is a pan and a ceph, and you're right. But the standard of care never allowed for taking roots intentionally and pushing them out of the alveolar housing. It's assumed that when we do orthodontics, we're keeping the teeth in a healthy environment within the alveolar housing. So here is really the bottom line. And unfortunately, it's related to money. When a dentist that has a digital pan in his office needs to replace that digital pan, the cost difference between the digital pan and a cone beam CT is less and less every day. But the revenue that they can get from a cone beam CT versus a digital pan or a Panorex is significant. So do you think those general dentists are going to be pushing regular pans, or if the insurance allows for it, they're going to take cone beam CTs? So there's going to be a lot more cone beam CTs taken on our patients going forward into the future. And they're going to be able to recognize the general pattern of dehiscence from poorly planned orthodontic treatment, even in the absence of tissue recession, because that's a lagger. That doesn't usually occur for several years later. And if there is tissue dehiscence and they end up in a periodontist's office and the periodontist takes the cone beam, periodontist is more than likely to say, well, this is from your orthodontic treatment. And, well, I am finished. And if you want, I'll hang around for more questions.
Jeff, we do have a few questions.
Okay.
Would you consider sectional mechanics to retract cuspids while closing extraction space and delay bracketing the lower incisors?
Yes, definitely. I think that's a great way of doing it.
Okay. And what wire are you normally using when you start closing spaces? Do you colligate, for example, on the posterior segment to achieve posterior maximum anchorage, or do you keep it simple and just use power chain? And then do you then continue your normal wire sequence with the same closing mechanics?
Okay, so what I do is I try to get the thickest wire I can between the extraction space. It's not sectional mechanics, but I don't care if I have the anterior segment of that wire tied in. I'll bypass the anterior teeth and I'll start closing the space. If I can only get a 16 ni tie in there, I'll put a 16 ni tie in and I'll start pulling from both the buccal and lingual. I mean, you saw that incognito case. I didn't even have a wire attached to those cuspids, those ectopic cuspids. Once I get this extraction space closed, I start unraveling the lower incisors, and then I'll start engaging them, and then work up to I'm trying to get up to a stainless steel, a working stainless steel wire.
That's all the questions we have right now. Oh, I'm sorry, one more just popped in. Could you repeat the software that was used to predict the root dehiscence with standard treatment and with the alveolar position considered?
It wasn't are you talking about the case where the patient had the AGA appliance and I showed like pushing the teeth forward and then the adaptive resorption on the lingual? Is that just that like graphic simulation? Is that, or are you talking about in general?
I'm not sure. I'm not clear on the question.
Okay, well, the software, there's software that comes with all the cone beam machines that allows you to look at the root positions from all three planes of space. That's no matter what machine or you buy, that's going to be there. But in terms of predicting treatment using the merger of the DICOM file that's from the cone beam CT and the STL file from the digital scan, you can send that to, there are different labs that will do that for you. So in that particular example, I used Brius, which is a lingual system that you set the case up using a cone beam CT 3D reconstruction. So even though the bone is static, you can look and see where the roots are going to end up. Okay, so that also SureSmile, you probably heard of SureSmile, they have that ability as well. You can just order a set of what they call enhanced diagnostic models where you can send the DICOM, the STL, they'll send you back this 3D reconstruction that's all cleaned up, and then you can actually yourself manipulate the teeth to simulate different types of treatment. I think, you know, in terms of like residents, and when I was a resident, we used to simulate treatment using these wax models that we'd stick in hot water. I don't know if anybody remembers that, but if you when you simulate these treatments using virtual, you know, setups that incorporate the 3D reconstruction, you know, your eyes open, because you're like, well, wait a second, even though the bone's static, you know, if to align these teeth in a non-extraction environment, you know, half the roots out of the bone, it's gonna jump right out at you.
Yeah, you hit the mark with that. That's exactly what the member wanted to hear.
Oh, okay.
I'm not sure what everyone can see on their screens, but if anyone needs to get a hold of John DiFrancesco, I have his contact information. You can contact me directly, and I can get that to you. And again, on behalf of our entire study club, Dr. Miller, would like to thank you for opening our eyes to some stuff I'm sure a lot of us were not aware of.
Thank you. You're welcome. If anyone has any questions, I put my email up there as well.
And for those who may not have gotten on right at the beginning, we're going to try to have this lecture. It was recorded, and it should be on ViewMedi and possibly on YouTube.
Yep. I'll send you the link, and then you can distribute it to your membership.
Okay, will do. Thank you very much.
Okay, thank you so much for paying attention, and I appreciate the opportunity to be able to talk about cone beam CT and alveolar focused orthodontics.